today's report out, and looking forward to hearing some updates from work we've heard previously. So we'll go straight. We've got three lots of presentations. So in a normal way, we'll go through the presentations and then questions and comments at the end. So Tyra and Dominique, I could see you on the screen. So can we come over to you? Emily, let's go to you, and we'll come back to Tyra and Dominique.
We're just starting with my colleague Matthew first, and then I'll jump in.
Hi, good afternoon. I'm Matthew Quinton. I'm the Environment Manager for the Trust, working on this project with Emily and several other members, several of our colleagues. Our project was the Kaizen event around mobility aids, predominantly Let's Get Our Kit Back, and this is our 60-day report out. Just a quick recap on what the actual problem was we highlighted. Currently at Leeds teaching hospitals, there is no return system for mobility aids that have been issued. Not only does this put a financial burden on the trust, it also contributes highly to our carbon emissions. Many of the items which we hand out end up in skips, people's cupboards, garages, etc., and aren't actually making their way back to the trust. We did a patient survey in Northwest Leeds where 95% of the patients surveyed actually said they weren't told what to do with any aids when they were given them, when they were issued, how to bring them back, where we wanted them to go. So what we decided to do was see how we can get these aids back. Currently, last financial year, the trust spent in excess of £30,000 on these aids. And going forward, this now ties in very nicely with the Trust's 7 commitments, essentially around sustainability and finance. Okay, so these are just an example of some of the actions that we put together during the Kaizen event, highlighting the areas of there's no location, no visual controls. And for what we put together was working for our minor injuries team was to see if we could get walking aids returned back to the point of where they were issued. Unfortunately, we didn't get the results that we wanted. Only 2 pairs of crutches were actually returned to the LGI. So what we've been doing is actually looking at other ideas and going bigger and better. Emily?
Just to touch base on our target progress report. So we set our target at £500 in terms of cost. We haven't met that. I haven't heard back from procurement what urgent care have spent, but adult therapies in April and May have already spent £773 on mobility aids. Now, if we assume that minor injuries last year was 80% of the total expenditure, we can estimate they're probably going to have spent around £3,000. As Matthew said, we didn't get any returns or any significant returns, and our other quality measure was whether or not patients were given instructions to bring them back. We're not sure how many were given instructions, but we know it isn't everybody. As 2 days ago on social media, a patient did state that she was trying to return a pair of crutches to the LGI this week and was told that they can't reuse them because of health and safety, so they didn't take them back. So we know that the instructions haven't gone out to everybody. So in terms of next steps, as Matthew says, we're going bigger and better. We're going to do a test collection site at a recycling centre in Pudsey for a specified amount of time. We met the local councillor for Pudsey and the recycling centre manager on Wednesday night, and they have agreed to give us a plot of land, which is just in the middle picture there. And they're very supportive of the scheme. If this is successful, we'll aim to roll it out across Leeds for recycling centres. We're going to advertise the collection points or the collection point at Pudsey on the same social media portals that we used to get the feedback in the initial phase. Matthew's also set up a meeting with Leeds City Council to agree a trial set in the city centre to use municipal buildings for collections. And also we have been liaising with supermarkets to scope out what's required for a collection site there, with Asda and Morrison's coming back, and they are very much on board. So that's where we're going next with it. And that's everything, if there's any questions.
Fantastic, Emily and Matt. Thank you for that really important piece of work, and really nice to hear it connecting up with the commitment for around kind of sustainability and greener care. So really good, really good. So if you've got any questions, let's just hold those, because we'll keep moving. I'm not sure whether we've got Dominique and Tyra back yet, have we?
Yes, we've got sound now.
All right. Okay.
Earlier.
Fantastic. We can see you and hear you. Great. So can we go straight on to your imaging transfer RPIW 30-day report out? Thank you.
So good afternoon, everybody. My name is Tyra Pasha. I'm one of the X-ray team managers at St James's.
I'm Dominique Parker. I'm the facilities operational manager for the Portering Services.
And as you just said, we are both here to talk through the 30-day report out for timely imaging transfers. At the end of April, we undertook a RPIW week with the aim of trying to improve the efficiency of the inpatient journey to and from Chancellor Wing X-ray and ultrasound. Data collected during the lead up to the workshop demonstrated an influx of imaging requests at the end of ward round, causing batching. This then resulted in multiple patients being requested on the CARP system at the same time, causing backlogs in the portering system. This in turn then had significant waste implications for resources in terms of radiographer, sonographer and porters' skill and time, and inevitably has cost and flow implications. During the week itself, we found a few other defects that were also impacting the process. Firstly, equipment. Porters were spending a significant amount of time trying to locate the appropriate equipment for the patient transfer. And secondly, once the porter actually arrived on the ward, we found that communication had been an issue, in that patients weren't always aware that they were presenting or due to have an imaging examination. And sometimes the nursing staff also weren't aware that the patient was due to have an imaging test, meaning that the patient then wasn't ready for the transfer, causing a further delay. So in an effort to address these key areas that we found, we introduced a series of small tests of change, from which we were then able to agree 5 main PDSAs, and I'll just talk a little bit about through each of those. The first one being a transfer team, which consisted of a clinical support worker and a porter. And once that porter received the job on the radio, that team would then disperse. The CSW would go to the ward and ensure the patient was prepared for the porter arriving on the ward, ready for that patient transfer. We thought that was a really positive move, in that then it freed up the ward staff to continue with the nursing and other duties on the ward and their responsibilities to the other patients. That saved a lot of time in that respect. The second PDSA was a nurse in charge phone. Initially, this was enlisted to support with the ultrasound team. However, we very quickly realised that there wasn't actually the ultrasound demand from J9, because it was a J9 nurse in charge phone. However, we didn't want to lose this opportunity, and having significant demand from J9 in terms of plain film, we decided to trial that within our own department itself. That's been extremely positive, and it's been a really quick and accessible way of communicating with the ward, and again trying to eliminate some of those delays, as the wards are now aware that those patients are due for imaging. So the third PDSA was quite a big one, in that basically we changed our working process a little bit, in terms of the X-ray coordinator would phone the ward once having received the request, and would phone the ward for important information such as mode of transport, whether the patient required O2, IV, or whether they were source isolated, meaning that the patients were then prepared for X-ray in the correct manner. The information that we were putting onto CARPS was accurate, and also then preventing that delay when the porter arrived on the ward. The fourth PDSA was where we talked about equipment. So we were finding that porters were struggling to locate equipment in a timely manner, again delaying that patient transfer. And what we did on CARPS, we had recurring slots, one in the morning, one early afternoon, so that a porter would then go and ensure a minimum stock level in the holding areas, so that when those patient transfers were ready to be completed, equipment was available for that transfer in an appropriate way and timely manner. The last and final one was one of my favourites, the golden patient. And as I talked earlier about the batching of requests, so I'm really pleased to sort of report that initially it was a small test of change, where the first patient of the ward round, we asked the doctors to request in flow. And on that particular case, we realised that the patient was requested sooner, had their images sooner, and basically then the results were available for that doctor sooner, to be able to then process the patient in terms of treatment or discharge, and that was done in a much more effective timely manner. And the second thing to report on that is we've had really successful upscaling of that process. We've now got excellent engagement from J12 again. They're our golden ward now. And basically we are currently, since the start of this week, we are requesting inflow for all patients. And although our data is quite limited, only a week's worth so far, so good. In terms of we are seeing a difference in that our patients are basically being imaged easier and therefore able to be treated earlier within the working day. We've also asked for feedback from the doctors involved currently, and it's been really positive.
So with regards to the target progress report, the baseline data was taken from all of the tasks in 2023 that the portering team carried out from any ward in St James's to either X-ray or ultrasound. So the baseline for the lead time, which is when the request for the scan was received by X-ray or ultrasound, right till the patients had the scan and been returned back to the ward. So the baseline is 3 hours and 11 minutes for X-ray and 15 hours and 52 minutes for ultrasound. We're really pleased to report that following the test of change that we've done, we've actually reduced this down to 2 hours and 3 minutes for X-ray, which is a 35% improvement. Unfortunately, we don't have the data for ultrasound, but we will have that for the 60-day report out. The sub-lead time, which is the time it takes for the job to be allocated to the porter and for the patient to arrive at the location, was 26 minutes in 2023. And again, we've had a significant improvement with that, with the test of changes that we've done, and that's reduced down to 17 minutes. Regarding quality, we looked at the defects, such as the delays on the ward, the patient wasn't ready. Now that X-ray have been calling the wards in advance to ensure that the patient is ready and that all of the information is correct as the doctor put on the request, this is now reduced down to 12%. With regards to quality, this was about how many tasks were taking longer than 30 minutes to allocate to a porter. Baseline data from 2023 showed that it was 25.77%. There's been a slight increase in this, so that 14% at the end, apologies, should be showing in red. The reason for the increase is the sample size. So the 140 tasks that we looked at, we found only 42 defects. So what we're going to look at is a similar sample size for the 60-day report out, so we've got a better comparison. With regards to morale, the staff said that they rated it 5.53 out of 10 in terms of the process. Following the changes that we've put in place, that's now increased to 6.14, which is an 11% increase. And then most importantly, the patient. They scored this as 7.87% for the process and the experience that they received. This has now increased to a 10, which is excellent news. So what went well? The collaborative working with MDT was amazing. We couldn't have done it without their help. We've all shared a common goal. So this has all been about the patient, their experience, and also linked in with the Trust 7 commitments in terms of reducing the patient's wait times and also their length of stay. We've had great consistency in continuing the PDSAs. The test of change for the transfer team have been amazing. Every time we've done a test of change, we've learned so much interesting information of what will work, what won't work, and then we adapt it for the next test of change. The support and engagement that we've got from the wards has been invaluable, and also the positive data results on the target progress report speak for themselves. In terms of our staff's engagement, obviously radiology and portering have been attending huddles and briefings where we've kept them updated with the progress. And then they've also been really important in terms of the feedback and completing the questionnaires in order to get them scores. So what would we do differently? We did decide early on in the RPIW that we were going to utilise trust-wide comms such as screensavers so that we could get the message out there, what we were doing and why we were doing it. And had we have done that, we probably would have got even more support and engagement and seen even better results. More patient feedback so that we've got a larger sample size, and also the delegation of tasks. So our next steps are that we're going to look to introduce trusted members of our team to support us with this. Obviously, it's a big task that's snowballed into more. And if we can bring people on board to help us with the test of change, then we can make even more improvements and get even more data to back that up. Looking to upscale the PDSAs, like Tyra said, Ward 12, we've already upscaled that. So can we now roll that out to other wards and upscale that further? And doing more tests of change for the transfer team to see where this transfer team will benefit the trust most, which ultimately benefits the portering service and the radiology, which is the purpose of the RPIW in the first place. So we look forward to doing the 60-day report out in 30 days' time, and we thank you for your time today.
Brilliant. Thank you very much, Dominique and Tara. That's really, really great work, and actually real progress. Feels like something that the whole organisation should be taking that learning from, because there's lots of learning, I think, from that, but also then how that might apply to lots of other things that we have to do when we're moving patients around the organisation. So thank you very much for that. Brilliant. Let's go straight on, if we could, to, is it Sarah?
It's Sarah.
Sarah, hi Sarah.
Yep.
Sorry.
Hi.
Can we come straight to you?
Yep, that's fine. So, hi everyone. My name's Sarah. I'm the business support team leader here at the Clinical Research Network Yorkshire and Humber. So, my project was around the procurement process and updating the SOP, which we created in 2021. Since then, there'd been a number of changes, for example, in relation to the Oracle system. The impact of the CSU moving to a hybrid working pattern also meant that we needed to look at how deliveries were managed. The feedback received from team members was that the existing SOP was not comprehensive enough and the knowledge of using Oracle was limited in the team, which was potentially the main reason for some of the issues escalated to myself. So what did I do? I introduced an issues log spreadsheet with my team and encouraged them to log anything they don't like about the existing process and provide any examples of order issues over a 6 weeks period. I conducted a process mapping exercise with the team, which helped to identify the wastes. We also did some brainstorming on potential solutions. I engaged with the relevant stakeholders such as the procurement and finance team to understand some of the issues from their perspectives. And during this project phase, it was very much about creating an inclusive organisational culture and creating opportunities for people to actively participate in the change. So this slide, it shows the top 4 wastes that we identified against the outcomes, which included an SOP, a team rota for managing deliveries, a robust invoices tracker, and staff training sessions, and the implementation of a purchase order form. Qualitative data was used to measure the success, and this slide shows the positive feedback received from staff with regards to the new SOP. I've also linked this to the Leeds Way behaviours of fair, accountable and collaborative as a way of demonstrating how these have been put into practice when approaching the task of creating an SOP and reviewing a new process. So the project has highlighted the positive impact of working collaboratively. An example is the discussions we had with the procurement team, which led to them offering bespoke training sessions. The interventions haven't just resulted in efficiencies in the process, but also clarity on roles and responsibilities. And the positive feedback from staff highlights this. The main challenges, I would say, was gaining access to quantitative data and the time commitment for completing the 4 PDSAs simultaneously. So I just wanted to summarise by reflecting on something I learned as a team leader during this project, which is that leadership is not about doing everything yourself. It's about inspiring and energising your team to lead the change. Thanks for listening.
Thank you very much, Sarah. Thank you for that, and great presentation. So look, we've had 3. I think that last one, your own personal reflections on that, Sarah, I think is really inspiring to see how this really resonates with our Leeds Way values and how we support each other in the work that we're doing. So 3 great presentations, all of which can have a massive impact for both the way teams are working and feeling about their work, but also then a knock on to how we look after the patients that we serve. And also a big well done to everybody actually for 3 presentations, all of which stuck to time. So sometimes we feel a bit tense at this point, but we've got plenty of time for some questions and comments, thanks to some very lean presentation. So well done on those as well. So let's open it out. Let's get some questions, comments from the audience. Jenny.
Good to see you all. I'm really sorry I missed the first one. I was running a little bit late. A few comments really. So I love now that our report outs are much more collaborative. I think Sarah, you made the point, but Dominica and Tara, the fact that you've brought your two functions together in order to problem solve, and it's great to see sort of flow happening. You realise just how much everything we do in the hospital relies on flow, doesn't it? And really brilliant to see. I loved, Sarah, that you got the feedback on the SOP from the users of the SOP. Thought that was brilliant. So often we will sort of measure staff satisfaction before and after, but great to see that feedback around, particularly that bit that said this is the great SOP. It's really useful, really easy to read. And I've got to say the highlight of the report out has got to have been that reflection, Sarah. I thought that was absolutely spot on. Well done.
Thank you.
Thanks, Jenny. Anyone else wanting to come in? If I can just, oh, Jimmy.
I feel like I've jumped on your comment there, Phil. Thank you. Great way to end the week. Phil kindly joined an executive seminar we hosted on behalf of another trust earlier in the week, as did Jenny. And one of the themes that we were talking about was how our method reaches people. And I shared that I thought that, in my language, cross-functional management was something we were still working hard at. So that's how do we work really effectively across pathways of care rather than our individual CSUs. And I should probably have held my tongue a little bit, because I think what we've heard here is actually, there's certainly some brilliant examples of where you're doing that really well. And a little bit just to pick up on Jenny's point around flow, and I do like my numbers, as you know, but it sounds fairly modest, perhaps 17 minutes of task time for porters. But I have been, and others would know, the number of teams that say we need our own porters. It's such a precious resource. So if in those thousands of jobs, and it's early days, but if in those thousands of jobs it takes 7 minutes less per job, then how many more patients are getting the intervention? How many more teams are saying, oh, we weren't waiting for our porters today as much as we might have done before? So I think I want to just emphasize that. I love the facts as well. I'm going to call out one final thing, so indulge me. When the suggestion about the doctors requesting tests during the ward round came out, there was quite a lot of, oh, they won't do that. No, them doctors, they won't want to do that. And I think the wry smiles you can see from Dominique and Tyra there tell the story that it turns out that actually they would try it, because we asked them just to do one, and then they quite liked it. So now they're going to do a few more. And the net benefit of that could be massive, both for the patients waiting for their tests, who might then move further in their pathway. It's a green day. And also for the teams that are waiting to do their work, and to do their work, they need the patients with them. So I'm going to pause there. I could go on all day. Brilliant work, everyone. I'm also going to call myself out. I was a bit late joining. I missed the first one, so I can't comment in detail, but I'm sure it was great. Thanks, Phil.
Thanks, Jimmy. Thanks for that. Really great reflections there. So I just, perhaps particularly for Emily and Matt, just had a question about what the opportunities are now to work outside the organisation, particularly across Leeds as a city, thinking that there must be quite a lot of overlap with kind of community and other services around the opportunities here. I don't know what you think, what your thoughts would be about that.
I think, go on, Matt, sorry.
No, go on, you go first.
I think we're hoping to get Leeds Equipment Services involved in the next phase to see how we can work together to streamline how we're getting equipment to patients. We know that there's issues as well around nursing homes and care homes that have got an abundance of stock that Leeds Equipment Services currently aren't able to pick up. So they're filling skips with with what essentially we need. So we can certainly look there. And as we were saying, like the supermarkets getting on board with us is brilliant, because ultimately that's you know, the idea, it's best for anybody. You go to a supermarket every week, so it's much easier to take something back to a supermarket than it has been to bring it back to minor injuries where there's nowhere to park. So.
Yeah, great. I think that's really something we should really help you with as much as we can then to get this out across the city, because I think there's some big opportunities there. Chris, you wanted to come in?
Yeah, thanks, Phil. I think the other thing, Matt, and obviously myself and Matthew work quite closely together, but for yourself, Emily, we have a huge transport network across Leeds, West Yorkshire. So we have vehicles often crisscrossing, doing other things. So I think there's a way to kind of pick these up from care homes, from supermarkets, etc., etc. So at really no cost. And if we kind of link those two plans, that's a really good way of getting these, these items back. So yeah, bear us in mind, and we can get some of the transport guys involved helping you as well.
Great, thanks, Chris.
Brilliant.
So I was going to just then quickly ask Tyra and Dominique, perhaps in particular, but obviously patients get moved around a lot for, theatres, procedures or whatever. Do you think that what you've done would be, lots of opportunity to think about getting those teams to think about this as well?
Absolutely. I think the level of upskilling that can be done and how far and wide this can be rolled out is immense. And perhaps I underestimated that in the beginning too. The last 30 days, obviously the process workshop week itself taught me a lot. It taught me a lot. But as we keep mentioning, I think the key thing here is the collaborative working, and I definitely think a lot of CSUs can benefit from this, and the trust as a whole.
And just to add from my side, some of the challenges that we found within that week are applicable to other CSUs such as theatres. So definitely some of the waste, we can look at how that can be reduced for them as well.
Yeah, good. That'd be really good to pick up actually, and I think that'll be something we can talk to teams around. And Sarah, just finally, for you, it sounds like one of the big learning bits was your own sort of personal reflections on that. So is there anything you're going to be doing differently from now on then, do you think?
I think personally, it's creating more autonomy in the team. So looking at what skills we've got in the team and basically energizing them, really getting people more involved with processes going forward, really, rather than doing it isolated. I think sometimes as managers we forget, when we get told you need to create a new SOP, we do it in a very isolated way, and we think that is the right way. But yeah, I think it's just that mindset of coming out, being more collaborative with the team.
Fantastic. What a great note to end on. I think this last half hour has been hugely energizing. So big thanks again, Tyra, Dominique, Emily, Matt, Sarah. I think 3 great presentations, 3 fantastic pieces of work. So well done to everybody, and thanks for presenting. Brilliant report out. See you next time. Cheers.
That was a brilliant report out.